The last speaker is, and certainly not least, is George Sledge, who's winning the Joe Rose Award this year. And George, and I'll have more things to say about him when we have our luncheon later, but he is not only individually accomplished, but also is symbolic, as we all are, of a certain type of person that you want to support and that you do support, the person who can actually take things from the laboratory and do the incredible difficult task of shepherding them through the process so they could actually go out into clinical studies in meaningful ways so that the results of those studies could help people. And this is not an easy task by any stretch of the imagination. It is something that requires enormous skill, actually enormous talent, and is not commonly rewarded, by the way, by our system, which is very hero-driven science. I've seen time and time again the people who take an idea and actually bring it all the way to actually help people with it, and then the award goes to somebody who made the discovery in the laboratory that the molecule that eventually got turned into a drug, that molecule did something along some pathway. That person gets into the National Academy, gets other major awards. The person who actually takes that observation and brings it through the difficult system so that it actually can help people commonly is ignored by the system. Well, we as an organization are not going to ignore that important step. And George, in addition to other things, has been a great mentor. Kathy Miller has already been mentioned. He has really been somebody who's dedicated his life really to helping other people develop the skills that are necessary to do this task. So it's a great pleasure and honor for me to introduce George Sledge.
Thank you, Larry, for those kind words. Cancer research, as you've already heard, is a collaborative effort. Isaac Newton's great statement was that if he had seen further than others, it was because he had stood on the shoulders of giants. And that certainly has been true in my career. And actually, I have gotten the use of giants at this table, in fact, throughout my career. About a decade ago, based on the laboratory research that Dr. Folkman and others had developed, we had a pretty good sense that new blood vessel formation was important in breast cancer patients, but we didn't know what was actually going to happen when we started using these agents in patients. And I must say, when I first started using bevacizumab, the agent that we eventually took into phase 3 trials, we didn't know if patients were going to respond. We didn't know if they were going to have some terrible toxicity because we were somehow shutting down their blood vessels. And I, to this day, remember ever so strongly the very first patient that we ever saw with a response. A young woman who had had multiple prior therapies for her disease and who basically came to us because she had nothing left to do. And my research nurse, Latrice Haney, hauled me one Friday afternoon to the X-ray place. We put her CT scans up in the box. We saw for the very first time a shrinkage of a tumor with an anti-angiogenic agent in breast cancer. And we spent the next 5 minutes dancing.
George, you want to show us what that looks like?
It's not a pretty picture. Dancing in front of an X-ray box and looking totally silly, which I think is hopefully gives you some sense of how thrilling it is as a clinical researcher to bring a new agent forward. We then had to ask the question, how are we actually going to use this in patients? Because when we bring new agents in, we always bring it in the context of existing therapies. And this is where the Breast Cancer Research Foundation came in with the very first research dollars I ever received from the BCRF. We approached this question by saying, if we're going to use this in the context of existing agents, how should we do this? And we reasoned because there was some growing evidence that actually some chemotherapy agents might actually target new blood vessels. And we, in preclinical work, both in cell lines and in mice, we were able to demonstrate, our group, Kathy Miller, Chris Sweeney, and myself, that the combination of bevacizumab with a chemotherapeutic agent, docetaxel, was significantly better at killing off new blood vessels than was the anti-angiogenic agent in and of itself. And based upon this work, which, and this is a refrain that you'll hear over and over again from BCRF fundees, would never have been funded by the National Cancer Institute. We developed this in a clinical trial that Nancy's already outlined called E2100, led by my close collaborator Kathy Miller, which for the very first time established in a large proof of concept trial that we could significantly alter the outcome of patients with advanced disease. So those of you who have been BCRF supporters over the years, I want you to know ever so strongly that what you support actually makes a difference to real patients. And it's had a huge impact in terms of where we're going in breast cancer. Based on the trial that Nancy mentioned to you, we're now launching a very large international trial. It goes by the lovely name of E5103, which is looking to see whether or not, for the very first time, we can not just cause advanced tumors to shrink, but whether or not we might be able to improve the cure rate for women with early stage breast cancer. This trial will take many years. It'll take the work of hundreds of collaborators and thousands of brave women with early stage breast cancer. But our hope certainly is that well within the next decade, we'll be able to demonstrate that we've truly altered how women with early stage breast cancer do, and that we've truly increased the likelihood of those women being cured of their disease. So again, I thank you all ever so much.